Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my wonderful wife, Janet, and we are streaming live from the Moses Lake Professional Pharmacy Studio, as we do every Monday, 12:30 to 1:30 Pacific Standard Time, on YouTube, on Facebook, and Twitter and LinkedIn. So follow us on those platforms. Look up my name on most of those, or the Moses Lake Professional Pharmacy YouTube site, and it will come up. And today I'm super excited to welcome back. I love second time, third time, multiple time guests. I want to welcome back Dr. Brad Brown. He is fresh out of residency, and he started a direct primary care practice right out of residency. And he's going to tell us a little bit about that story and update us on that, and how him and his brother have developed some special software. So, Dr. Brown, welcome to our show.
Thank you. Thanks for having me back. It means I did something right last time. Right?
Yeah, you did. Yeah, I love to have you on, and I love your story. One of the things I like about your story is that there are so many doctors that get out of school, and you knew about it early. I mean, even in school, you're like, when you're in residency, you're like, this is not going to work for me. I am not going to be able to be a doctor and make a career out of this in the traditional sense of having a practice. So you decided to go into direct primary care straight out of residency. So no guaranteed income, no big income from a big corporate clinic, no big guaranteed income from a hospital. Tell us, how did you do that?
Well, that is I don't know if we have enough time to go through it all. So yeah, in medical school, I rotated with a DPC doc in Phoenix, and he, turned me on to the idea of direct primary care. And I always knew I wanted to be in the primary care realm professionally, and family medicine spoke to me pretty early on. And then as I rotated with him a couple different times, we became friends. He's kind of a friend-tor, if you will. Then I knew I knew that I wanted to start my own thing. I kind of have an entrepreneurial itch that I just can't scratch. And so I figured this was the best way to at least try to do that. And then once I got to residency, I had a very favorable residency program that allowed me to explore how to get it off the ground and how to at least lay the groundwork before I was done. And about halfway through residency, me and my big mouth, I guess we can blame it on, word got out in the town that I'm in, just north of Denver, that a new doctor was coming to town. I signed a lease on a space thinking, it was a perfect space, wrong time, I'll just sit on it. And then word got out and people wanted to start signing up. And so I figured, oh crap, it's more of a ask forgiveness and permission thing with my residency. So I can say that now because there were definitely a couple of headaches early on. But no, it's been fun. We one other doc, I'm sitting in my clinic right now. She's just on the other side of the wall. We are kind of going at it together, and it's an absolute blast. I mean, I don't do well with authority telling me what to do, I guess, if I can put that respectfully. And so I figured just kind of sticking it to the man and going out and doing it on my own was it was going to be fun, and it's been an absolute blast. So we've been open for about 18 months technically. I've been out of residency about 4.5 months, and just cooking along.
Janet, what questions do you have for Dr. Brown?
So I got to hit you on the authority thing. So, right. So was that you just didn't think you could work in a big clinic setting or a hospital, or how did that play out in your thought process?
Yeah.
About.
So that's an excellent question. So for me personally, I struggled during residency when someone in a suit and tie, male or female, would tell us about quality metrics and patient care when clearly they had never sat across from someone in a room in a 3-minute visit and telling them they have cancer, or right. Trying to treat their diabetes when they, obviously they don't have time or money and they're telling us you need to do this. I really struggled with that side of things, as well as one of the other sides of treating to what insurance companies would cover. I really struggled with as well. I found that to be extremely detrimental to the patient's health. And so removing those two pieces and allowing me to focus on what the patient needs, and then being there with unrestricted access is extremely professionally rewarding, right? And so I mean, we can sit. I have a couch right here. This is where I see patients. We have an exam room with an exam table, but this is where we see people. And allowing them to open up and feel comfortable meant a lot to me, And so I didn't. Sure, I population health and all those things. Yeah, well, that's baked into our practice, but it's not. Hey, you need an MRI. Sorry, insurance won't cover it, so we're not going to do it. It's, hey, let's figure out the best way, and we have the bandwidth to be able to support the patients that need it most.
One thing that, thank you for that, and thank you for being independent. I think one of the issues we have with medicine, and in fact, I'm sure you've heard it in your circles, is that doctors need to take back medicine, period. I mean, 25 or 30 years ago, I mean, even 20 years ago, doctors were in charge. There were no people, like you said, with suits across the table that were non-medical doctors telling you what to do. The doctors, they called the shots. I mean, they told administrators what to do all the time. And it wasn't until the last, 15, 20 years that it had flipped around. And, I think a generation or plus ago, doctors went to med school because they were independent people. They weren't yes to people. And I think, unfortunately, now is that a lot of the ways that a lot of the doctors that go into medical school are yes people. And I think in some ways, Dr. Brown, is the system likes it that way. Can you comment on that?
Shawn, we've talked about this before. You're asking me to get on my soapbox, and I got to. Yeah, I mean, it's the system. People describe it as broken or whatever. The system is exactly what health insurance companies want it to be right now. Vague, opaque. No one really knows what's going on. It's a third-party system, but is it really? Very political, which we'll leave for another day. But the system is exactly what it was built to be right now, which is not great at all for patients. We're all patients too,
right.
And as well as healthcare professionals, doctors, pharmacists, everyone in the game. And so it's extremely frustrating to have those red tape handcuffs. And so to find ways to be the change that you want to be is kind of what the whole direct primary care movement is. There's a saying that, once you've seen one DPC, you've seen one DPC, is because we all kind of have our own flavor. It's basically letting the consumer vote with their dollar of, hey, this doctor over here has this price, and I really connect with that person, whereas I don't connect with Dr. Brown, so I'm going to go over here, and vice versa. It's okay, off the soapbox. I have to slow down.
No, go. That's why we have you on.
No, it's the system is doing what it has been built to do, and so the healthcare professionals are. I hate to play the victim card, but I know fantastic physicians and pharmacists and PAs and NPs and nurses and everyone who are stuck in the hamster wheel of the system. It's not like it's not like I give better care to my patients in DPC, because those physicians are fantastic as well. I just have the time and the bandwidth, and I've removed direct primary care removes the adverse incentives of bringing people in as much as you can, so you can bill every time they come in. You can bill insurance, or okay, I can go off forever, but you get the point. So yeah.
Well, go ahead.
Go ahead.
Well, I think one of the things that a DPC doctor actually said, and I think it was on our podcast one time, he said in order to change the system, he felt like he had to get out of the system. And I think that's essentially what DPC doctors have done, or pharmacists like ourselves.
Yeah.
I honestly, call me negative, call me pessimistic, but these doctors, these pharmacists, and I follow some of them on social media that are trying to change the system and change the way PBMs work and the way insurance companies work. It ain't going to happen.
They're a couple commas short on their funding.
Exactly.
Yeah.
It's not going to happen. So the only way to do it is to get out of the system. That's the way to change the system.
You can't change anything if you think the same way of how it was created. You got to think differently, and I'm just riding that wave.
Right. Well, I will say this, from my own personal journey, Dr. Brown, one of the things that's so encouraging, and it happened just today, like a few hours ago, we had a client that came in and he's seen somebody with direct primary care and he's lost weight. He's off of all his diabetic medication. He has he looks amazing. And you know what? You can tell, and he's telling everybody. And that's the outcome I wanted when I graduated from school, is that I wanted to see that person turn around and make a better choice for himself and how it impacts him in the life of his family, kids, his neighbors, his coworkers. That's what it was all about, right? It wasn't like, oh, here's another prescription to take care of that side effect that you're having. We wanted to see impacts in somebody's health choices. And when you have 3 minutes as a prescriber or a doctor, logically, that doesn't make any sense.
The only thing you can do is prescribe. You can't really talk about lifestyle modifications, which is the way it's what the system likes. Big pharma and insurance companies love those 5-minute visits because the only thing you have time to do is prescribe something.
But opening the door to a DPC and giving that client the availability of your knowledge and your time, his outcome. And then you have somebody else in the community that's going to be affected too, because people that have good outcomes, they're sharing. They're like, hey, go to these people. They know what they're doing. They have time to. And I feel like the reason I'm so impassioned about this is because I hear this a lot. Well, people aren't going to change. People aren't going to. And I'm like, how do you know?
That's a cop out. I think that's a cop out for a lazy pharmacist, for a lazy doctor, thinking, oh, people aren't going to change their lifestyle. That's lazy.
Oh, you're just old. It's like that's
right. We hear that all the time.
Right? That answer. Oh, I'm just getting old. No, I'm sorry. That is not.
No,
not it.
No.
But no, we hear one of the mantras that we kind of have fallen into that we didn't set out to have. It's not like this is one of our pillars here at Strive. Is sure. It's really, really challenging to change the world, especially kind of just, in the small setting like this. But we feel like we're changing the world for each patient. We're changing their world, and that's kind of something that has just happened. That wasn't like our mission statement, but we've really seen it. We've seen outcomes like that too, Janet, where it's like, that is what gets us up in the morning. I only live 1.3 miles from here, and I was walking in today and I was just amped. I'm like, this is great. I cannot wait to hear what people have to say today on Monday morning. So,
well, and speaking of that, it is obvious, Dr. Brown, how you are passionate about what you do. And I will tell you, most DPC doctors are. They're very happy. I would say all of them are, honestly. I know all's a strong word, but you just don't see doctors that have the passion in the traditional medical system because they really don't have a lot of control over their own work environment.
Yeah.
So, they don't have the passion. That's a problem. Do you really want a doctor taking care of you that doesn't really care about their job? Yeah. Seriously. Not even maybe. So that's one thing I noticed right away. And I was going to say that it's obvious that you are having fun doing what you're doing. And we should. We should have a passion for what we're doing.
Yeah, absolutely. And we built this space from the ground up, and I'm 6'7", 6'8" with shoes on. We have 8-foot doors and 12-foot ceilings, and so I can't not love coming here, for crying out loud. Sure, patient care is great, but I can actually stand up straight in my own clinic.
Oh.
Right. So, tell us, you've only been at it for 4 months, at least, since you've been out of school. But tell us a story. Janet just shared a story. Tell us a story how you have changed somebody's world, like you talked about, over the last 4 months.
Sure. Let's see. So one family comes to mind. They have a few kids. I think there's 5 or 6 or 7 of them under the age of 10 or 11. It's a big family. I grew up in a similar family, so they have a special spot in my heart. They were headed downtown for a like a Disney on Ice type thing. The kids were pumped. They've been waiting for months to this. And I think it was a Friday afternoon. And I get a text from the mom saying, hey, our youngest there's a Lego stuck up their nose,
Oh my gosh.
Great.
Yeah.
Meet me at the clinic, because I was already home. I said, meet me at the clinic. We'll get rid of it. No problem. So on their way to the Disney on Ice, they swing by the clinic. We pop it out real quick, and all the kids stayed in the car. Just the mom came in with the youngest. And then they went on their way. And in my mind, I'm like, usually they'd get turfed to urgent care. It'd be a couple hours waiting. That's a small thing. Sure, they didn't lose a ton of weight. Sure, they didn't get off all their meds. But it's like that type of thing is why I love this, is because it's medicine and primary care for our life today. I just need a quick Lego out of my nose, for crying out loud. I don't want to go sit at the children's hospital for 6 hours.
Yeah.
And so I loved that, and obviously they loved it too. They're very, very grateful. But
they would have missed Disney on Ice for sure.
They would have, no doubt.
And let's just be really honest, Dr. Brown. It would have been an 8 to 12 hour adventure. I mean, seriously, it probably would have. Maybe an urgent care, no, but if it was later at night, ER for sure.
Definitely.
And let's talk about price. At least $1,000 in the urgent care. And we have no idea because there's no transparency and there's all these surprises.
Yeah.
But tell us what your fees are for direct primary care and how that was covered under that.
Sure. So we have it age-based tiers. 45 and above is $105 a month. 18 to 44 is $85 a month. And then younger than 18 is only $40 a month. And so that was all covered. We have unrestricted access. It was whatever you need. You just swing by. They came by. It was a free Lego removal, all included. I should put that on my website, actually.
Right.
No, so it was, it's all, texts, calls, emails, FaceTime, whatever they need. And I actually did have a mom the other day email me a picture of her son's, a 7-year-old's arm that was kind of like shaped like it was crooked. I was like, hey, that's a little more urgent. You should probably call for that one. But she's like, well, I didn't want to disturb. Patients are extremely respectful of our time, and it almost to a fault. I said, hey, that's one of the times you should probably just call me.
You know why that is? So we feel that way about our patients too. And when we have team members come from, another XYZ pharmacy, they'll say about how nice our patients are and how our patients are different. Well, we come from the same area, right?
Yeah.
So, but you know what's different? It's how we treat them. We respect their time, and they respect our time. And honestly, if the doctor's only going to give you 3 minutes of time, do you expect them to respect you? I mean, seriously. I mean, you have a comment on that?
That's a great point. I mean, it's you give a mouse a cookie, you give someone just a little bit, and if they know that's all they're going to get, they're going to take as much as possible.
Right.
But if they know they have unrestricted access, they're like, hey, I'll just text you when I need you. I love that. And that's the first question. I'm sure you've heard it too, is, from other healthcare professionals wanting to do a direct care type of model, what about being on call 24/7? It's like, well, yeah, technically, but in the 18 months that I've technically been open, I've had maybe one call between the hours of 8 p.m. and 8 a.m., and it's like, it was at 7:30 in the morning, for goodness sakes. And so,
and you're right. And your colleagues that work at big corporate clinics, I know that things are a lot different with hospitalists and stuff now, but how often do those family practice doctors get call when they're on call at those big corporate clinics?
All the time. All night.
Every night. All night long. They just don't get sleep.
They don't stop ringing. Yeah. Metformin refills at 3 a.m. just kill me. I don't understand.
Right.
But, people know they can get directly to a doctor when they call after hours. So in my mind, it's like, why not do it during hours, for crying out loud? Yeah,
exactly. So you're in your entrepreneurial spirit and help with your brother, who must be an entrepreneur also. Yeah. You wanted to kind of develop your own software for DPC, correct?
Sure. Yeah.
And you did just that.
Yeah, that's the last 4 years in a nutshell, right there. We did just that. All right. No, my brother and my wife actually. She has her MBA and she kind of runs the whole thing. But it's called Aero DPC, AERO DPC. We're all cyclists, and so we went with the aerodynamic theme, but also to make your practice workflows more aerodynamic, I guess. Mm-hmm. It's pretty lame, but we went with it anyway. So in med school, when I was rotating with that same doc, he was using a well-known system, and in my mind, I was like, there's just got to be a better way. I mean, it's really simple. He already had outgrown it, and so the seed was planted. I talked to my brother. He was a senior level engineer at Amazon for a long time. But he's been working on Aero for 2.5 years full time now, and it's taken off like a rocket. We have quite a few new practices every week that sign up. It's a wild ride. It's kind of our thing is everything a DPC doctor needs in one integrative platform. So the whole tech stack is all in one tab on your browser. You don't have to sign in to 20 different things. And that has been, med school and residency was a learning curve, but learning like coding and everything, I don't know how to code, but just listening to him talk and my wife, it's like, well, being a doctor is easy compared to that.
I still don't understand the coding thing. Yeah. I understand pharmacy, but I do not understand the coding thing. It is like another language, literally.
It's like 7 different languages all I know. Yeah. And I'm a really proud human. Like, I can come across pretty prideful sometimes, but because I feel like I'm a really smart person, even though I'm not. But whenever I start hearing about code and everything that goes into it, my brain just stops. Like the cogs just get clogged. And I'm like, okay, right. whatever you think is best, let's do it.
Mm-hmm. So what sets Aero DPC apart, you feel?
Now you're asking for my biased answers. So yeah, everything all in one. There's the rest of the systems out there do one thing or a couple things, but we have all the EMR capabilities, billing, inventory management, faxing, texting, phone calls, all the electronic forms, everything is all rolled into one, e-prescribing as well. And it's not nickel and dimed. It's all at a rock bottom price, which is very startup friendly. So we have a lot of new practices that use us. And so we kind of set ourselves apart to where you don't need 20 logins. It's just all in one. It's all here. When you get a fax, there, bidirectional labs, it's there, e-prescribing, it's there. It's been fun. We'll put it that way.
Is it the only software out there that you know of that was actually that was designed by a DPC doc for DPC?
So Atlas with Josh Umber, he designed his, and he's a DPC doc. He's very well known. He's done fantastic things for the DPC community.
Yes, he has.
I've heard him talk quite a few times, and early on in my journey, he kind of inspired me to actually go for it. But he built Atlas, and they have theirs that was built by him as well. But the other ones are either retrofitted into DPC or only do one piece of what a doctor needs. So just communication or just billing or just EMR. So we were like, there's a space here that we can combine everything and do it all in one.
And then, of course, I'm assuming that there's a mobile app for Aero DPC, so you can control it all on your phone, correct?
Not one you can download from the App Store. It's all browser-based, so you can access.
Oh, yeah. Okay. Right.
Yeah. And so patients have a portal. Me as a physician, my wife and I went on an anniversary trip to Cancun a month or so ago, and I was responding to patients on, from the beach. It was fantastic. I shouldn't have. I know, but I did anyway, just to say that I did it.
Right.
There's a picture, of my feet with the beach out there, just like, being a doctor is great. I'm on the beach. But then Sarah, Dr. Schuster, she texted me right after. She's like, why are you responding? I'm like, well, I had to. I just had to at least once. But you can access it from anywhere. Patients have a portal. It's all browser based. There's nothing you have to download on your computer and everything.
That's actually kind of nice when things are browser based and web based instead of app based. Yeah. So tell us about your DPC. Every DPC, you kind of mentioned a little bit about. You didn't say free market, but how people have choices with DPC. It's like, well, this one doesn't fit me. This one does for whatever reason. And we've interviewed DPC, probably met or interviewed hundreds of them from around the nation.
Nice.
And the coolest thing is that they are also different. The pricing is so different.
Mm-hmm.
I love it because that's what really happens in a free market. You kind of have a la carte. It's like you decide what you want to pay for. In a traditional system, we could talk about that, but you don't get to decide at all. I mean,
Drop down on an insurance menu.
Yeah, right. It's insurance is deciding it. So, what kind of you probably didn't set out to do this, but what kind of sets you guys apart? Is it young families or internal medicine type stuff, or what kind of sets you guys apart?
That's a great question, and I mean we're still young in the game too, so we're still trying to hone in on that. But Sarah and I were both we like the full spectrum of family medicine, the womb to tomb, as they say.
Yeah.
And so we like all ages. We like the acute things. Both of us kind of do some locums work out on the eastern plains of Colorado, kind of in the ER realm. And so we tell our patients, hey, we're ER docs as well. And so whenever we say, hey, this needs to be seen in the ER, they trust us. Instead of Friday afternoon at 6 p.m., you have a leg go up your nose, you're getting turfed to urgent care. It's hey, we can take care of a lot of the things here. We're trained. We have that skill set. And if it's outside of our scope, they trust us to say, hey, this needs to be in the ER. But we have integrative medicine training as well, both of us. Sarah does a lot of women's health. I do too, but our demographic is generally young and healthy in the town that we're in. And so I've found it's quite interesting. It's totally off topic, so just tell me to shut up whenever. But usually the women under the age of 40 to 45 are requesting a female physician for women's health, or over 40 to 45 are like, it doesn't matter at all. And so our demographic skews a little bit younger. And so they go to Sarah for all the women's health. And then I do a lot of sports medicine and things like that, being a triathlete and endurance athlete. So we get kind of that as well. But the small business scene in the town we're in Erie, Colorado is fantastic. And so we have a lot of small businesses that use us as well. We're kind of jack of all trades.
That's awesome. That's awesome. So back on the topic of women's health.
Yeah.
So my grandma, who passed away a few years ago, in her 90s, short after I got out of pharmacy school, we were talking about women's health stuff, and she was having some issues, and she, so she was born in the 20s, I guess, probably, and she actually refused to let a woman.
It's interesting.
Women's health, yeah.
Yeah.
Right. Because back in that generation, it's like, no, you don't, that's not what you do. You have a male doctor. So she was just used to that. So she was very uncomfortable when she had a woman gynecologist.
And to that end, during residency, we would see a lot of the underserved population in the clinic, right? It was basically a safety net clinic. And I kind of took it upon myself. I always wanted to offer that to women, because a lot of women who maybe English is not their first language, or if they're living below the poverty line, if they're here, they just need a quick visit, they don't know what their choices are. And so I would always make it a point like, hey, if you prefer a female physician, there is no harm, no foul. We're still friends. That's kind of like a small vendetta of mine to be like, hey, you have a choice. You can speak up for your own health, especially women's health. I mean, that's something that can be
very personal. It's very personal. Yeah.
I don't want to be this tall 6'7" white male that comes in and says, hey, you need this. That's why I never wear a white coat, because A, I have a deep voice, B, I'm a white male, and C, it's very paternalistic, and so I wanted to give women that option of, hey, if you want a female physician, there's one 3 steps away that would be more than happy to do your pap smear, more than happy to do your breast exam. And it would be, if it goes back to the whole consumer experience. I mean, we're all consumers when it comes to our doctors, just like going to the mechanic. And so you want to have the best experience possible.
Yeah. We do the same thing at our pharmacy. We do a lot of women's health stuff and men's health. And, when I'm talking to a woman, I'll say, it's like, look, my wife's pharmacist also, if you would rather talk to her, that would be, it's not going to hurt my feelings at all.
Yeah, exactly.
And my wife will do the same thing with guys sometimes, because they won't open up to the same things to her as they will to me. So, we like to give them that option.
Absolutely.
So one thing you talked about you do a little bit of sports medicine because you're an athlete yourself, which I love that. I think one of the big issues with our healthcare system, it's not a big issue, but I think it is an issue, is that in general, healthcare providers are not healthy people. I mean, this is not a joke. This is true. I mean, if you don't believe that, go to your local hospital and go eat lunch there sometime and look at all the people that are eating lunch in scrubs. So they're probably working for the hospital and they're morbidly obese. I mean, it's just bad. It's bad for our patients. So kudos to you for being in good shape. I think we can't educate our patients appropriately about lifestyle choices if we're not making good choices ourselves, right?
I agree. And I think we've already touched on it. It's the system. Like the normal family doc sees 25 to 30 patients a day, and then they have to chart all night. So how in the world do they have time to work out?
Right.
I mean, it's just the same with nurses. I mean, they work their 3 or 4 12-hour shifts, and then they take the other 3 or 4 days to recover, for crying out loud,
Right.
Right. And pharmacists. So it's yeah.
Well, and I also think this too. I think, in a true free market, I'm a free market guy.
Me too.
I'll hit that. Yeah, I'll hit that over and over again, and I'll use some examples of that. It's like, so if patients actually chose, choose, people have to choose to go to you.
Oh yeah.
They're not told to go there by an insurance company. So let's say there is an athlete like myself, and which I've had before. I had a tendon. My Achilles tendon from pedaling wrong.
Sure.
Well, if I went to a doctor and he was 100 pounds overweight, there's no way. I mean, there was no way I would choose that guy. Yeah. I would choose somebody like yourself. Say, oh, well, about bikes. Okay, so help me out, because I don't want some doctor to just prescribe Vicodin or ibuprofen and say, yeah, it'll get better. Yeah, maybe it's my pedal stroke or whatever. So we would pick people depending on. We would grab depending on how they could help us. Mm-hmm. I always use this analogy. In fact, I use it in my book called Sickened: How the Government Ruined Healthcare.
Fantastic book, by the way, if anyone.
Thank you. And I use it. Would you ever choose to go to a dentist with crooked yellow teeth?
Yeah, no.
The answer is no. I mean, so why would you choose a doctor that is not metabolically healthy? I mean, those are just, and it's not a personal issue. It's just those are. It's kind of a challenge to us healthcare professionals to take better care of ourselves, because if we can't take care of ourselves, how are we going to take care of our patients?
Practice what you preach.
Yeah, right.
100% agree.
So as we wrap this podcast up, I usually ask what you have a passion for, but I'm gonna say that you have a passion for gravel racing on a bike, so we can talk about it.
Sure, let's do it.
Because you just bought a gravel bike, and I'm a Trek fan. Although Specialized makes great bikes, and their Roubaix is an awesome bike.
Way overpriced, but I pay it anyway.
Yeah. Right. And so tell us, you used to be a road racer, right? Road racing, or just competitive?
I wasn't ever ranked or in the CAT system or anything, but I casually, yes.
Yeah.
On the road.
And now you got a gravel bike. So if you had to pick one gravel race that is kind of like on your bucket list, what would it be?
That's a good question. Sheesh. There's just so many. I'm just so new in the gravel scene that I kind of want to do them all.
Right. I get it.
I've kind of done all the main road ones, all the amateur road ones. And I've dabbled in the Ironman series as well. And so I don't know. What would you say is the best one?
Well, they just changed the name. I can't remember what it's called, but it's part of the Grand Prix series. It used to be called Dirty Kansas in Kansas.
Oh yeah, yeah.
It's by far, but because it's politically incorrect, they changed that name. Whatever.
Yeah.
It's by far and away like the biggest gravel race in the nation.
Nice.
And they have a 125 miler, which would be more speed. I don't like them more than 5 or 6 hours.
Yeah.
But they also have a 250, and people are finishing in. Some of those guys finish in like 10 hours, 250 miles in 10 hours.
Yeah,
it's like,
that's ridiculous.
Or less or something. It's crazy.
Yeah.
But that would be mine. I've done some really cool ones. I mean, but as you can imagine, Washington being the Pacific Northwest and the Cascades, we've got some cool ones up here.
Yeah, absolutely.
There's one.
Goes around Rainier too. I've heard one that goes around Rainier.
Yeah, Ramrod.
Yep.
And it's all paved though.
Is it? Okay.
Ramrod's all paved. But Winthrop is a good one. It's about 90 miles, and it's 90 miles, and is it 80 or 90? I can't remember, but 15,000 feet of climbing.
That's a decent amount.
Yeah, okay. Mostly on gravel /fire roads. So Yeah.
We'll do it next year. How about that?
Yeah. But in your area, you could do the Leadville. I mean, there's people that do the Lead.
That's more of a mountain bike race.
Oh, but the fastest guys do it on, unless they're sponsored by mountain bikes, they do it on gravel bikes because it's mostly double track from what I heard.
Yeah, the guy who won it last year, he had a road tire on his rear wheel, and I'm just like, I don't know. I have too much to live for. I can't.
I know, right?
Yeah, but no, and my wife and I were big into trail running too, and so we're trying to figure out some good amateur trail races. And the Leadville one, the Hard Rock, those are just like insane. I mean, 30,000 feet of climbing for a run, for crying out loud, is just.
I know, right? That just crazy. Yeah.
Just to see how far you can push your kidneys.
Right. All right, Dr. Brown, you have helped us realize our goal today of educating and empowering individuals to take charge of their own health. So if somebody wants to get a hold of you and has questions, what's the best way to do that?
Best way is hop on the website, striveddirecthealth.com. It has all the contact info. You can message us. You can hop on the Facebook page, Strive Direct Health, Instagram. We're pretty reachable by any of the means. So just Google us, and we're here.
Sounds good. I so appreciate you. So thank you for being on today. Thank you, listeners and viewers, for tuning in. You've been listening to Health Solutions with Shawn and Janet Needham. Tune in Thursday, 8 to 9 a.m. We will have, I'm not sure who we have. Let me check really quick. Let's see. Oh yeah, we have a doctor on that's going to be talking about interstitial cystitis. He's a naturopath and how to fix that, and that's a very difficult disease to fix. So you want to tune into that, especially any women that have had interstitial cystitis. So if you know of anybody, share this so you can have them tune in. Thank you for listening and tuning in to Health Solutions with Shawn and Janet Needham.